Hello, I'm SA, your AI essayist. Please note that all content, audio and video in this presentation are AI generated. As AI can sometimes produce inaccuracies, I encourage you to verify any factual information presented. With that in mind, let's begin.
A diagnosis of cancer in the early 1990s presented a formidable medical challenge for a resident of a small mining town in southern Arizona, perhaps nestled in the Mule Mountains or along the Gila River. That challenge was compounded by an unforgiving geography. The journey to a specialized cancer center in Tucson or Phoenix was an odyssey measured in hundreds of miles, in days of lost wages, in the intricate coordination of precarious transportation and temporary lodging. This physical distance mirrored a profound cultural and psychological gap. The world of the tertiary academic medical center, with its advanced imaging suites, complex chemotherapy protocols, and bustling specialty clinics, felt a universe away from the familiar rhythms of rural life. Patients often arrived exhausted and disoriented, their cases becoming data points in a system designed for urban efficiency, a system ill-equipped to comprehend the profound logistical burdens that shaped their ability to receive and complete a course of treatment. The excellence of the medicine was seldom in question. Its accessibility, however, was a matter of considerable doubt. This was a landscape into which a young physician, Dr. Maria Lopez, stepped as she began her career. Her medical education at Columbia University's College of Physicians and Surgeons and her subsequent residency in internal medicine had prepared her for clinical rigor. Her fellowship in general internal medicine and endocrinology honed her diagnostic acumen. Yet it was her arrival at the University of Arizona and its burgeoning cancer center that crystallized the central intellectual problem that would define her life's work. Here, in this oasis of medical science surrounded by a vast, sparsely populated expanse, the theoretical inequities of healthcare access became stark, daily realities. She witnessed the pattern firsthand: patients traveling immense distances for an initial consultation, only to return to their communities where follow-up care was fragmented, and communication with their primary physicians was fraught with delays. The consequence was a tragic cascade of late-stage diagnoses, treatment interruptions, and a pervasive sense of abandonment among the very populations the center was meant to serve. Her initial response was one of deep, systematic observation. She saw that the problem was one of systems architecture. The prevailing model of care was centrical, demanding that all resources, expertise, and patients converge on a single, central point. This model, while effective for concentrating research and technology, created immense friction at its periphery. For a patient in a remote community, the academic medical center functioned as a black box. Information went in, a complex treatment plan came out, but the continuous, supportive feedback loop essential for oncological care was broken by distance and a lack of integrated infrastructure. The intellectual challenge, as she began to frame it, was to reimagine the delivery of specialized medicine itself. The question became how to project the expertise of the center outward, to embed its knowledge within the communities where patients actually lived. This line of inquiry represented a significant conceptual shift. The dominant conversation in academic medicine at the time revolved around molecular pathways, novel therapeutic agents, and the refinement of clinical trial methodologies. Dr. Lopez's thinking, by contrast, began to incorporate principles drawn from public health and medical anthropology. She recognized that a successful treatment outcome was contingent upon a patient's entire ecosystem of their family support, their financial stability, their cultural understanding of illness, and their trust in the medical establishment. A state-of-the-art chemotherapy regimen was of little use if the patient lacked reliable transportation to receive it. Her early work at Arizona, therefore, was grounded in a philosophy of practical humanism. It involved building bridges, one conversation at a time, with primary care providers across the state seeking to understand their challenges and co-create pathways for better communication and shared patient management. This perspective was profoundly shaped by her intellectual lineage. Her approach echoed the foundational principles of physicians like Jack Geiger and Count Gibson, whose pioneering work in the 1960s established the community health center model in the United States. Geiger's revolutionary idea, born from his experiences in apartheid South Africa, was that a health center's responsibility extended beyond the clinic walls into the social determinants of health. He famously wrote prescriptions for food, viewing malnutrition as a clinical diagnosis with a social cure. Similarly, Dr. Lopez began to view geographical isolation as a clinical risk factor, a comorbidity that required a specific, targeted intervention. Her work was animated by the same core belief that high-quality healthcare is a resource that must be actively delivered to people, its form and function adapted to the specific conditions of their lives. At the University of Arizona, she found mentors who nurtured this view. While the names of specific individuals remained within the sphere of her personal history, the institutional environment provided fertile ground. The university had a long-standing commitment to serving the state's diverse populations, including its large Hispanic and Native American communities. This created an atmosphere where questions of cultural competency and health equity were part of the academic discourse. Her focus on these issues was seen as a vital contribution to the university's public mission. She began to formulate a new kind of medical practice, one that saw the oncologist as a partner with the community, a collaborator with local physicians, and an advocate for systemic change. Her initial solutions were logistical and relational. They involved creating clearer communication protocols, developing educational materials for remote clinics, and championing the role of patient navigators who could act as guides through the bewildering healthcare labyrinth. These early efforts were foundational. They established the core principles that would animate her later, more technologically sophisticated innovations. Before she could build a virtual bridge with telemedicine, she first had to establish a human one built on trust and mutual respect. She demonstrated that understanding the patient's lived experience was a prerequisite for effective clinical intervention. This period of her career was one of problem definition. She meticulously documented the failures of the existing system and articulated a powerful, alternative vision. The central question had been posed with piercing clarity: how can the promise of academic medicine be fulfilled for those separated from it by the simple, yet profound, barrier of distance? The answer, she began to realize, would require a radical rethinking of the very meaning of a clinical encounter, setting the stage for a technological and philosophical revolution in the delivery of cancer care. The question of bridging vast distances to deliver specialized medical care, once a theoretical puzzle, found its practical and powerful answer in the work of Maria Lopez. Her intellectual journey led her from identifying the human cost of geographical isolation to architecting the very infrastructure that would render that isolation obsolete. The solution she championed was telemedicine, a concept she would elevate from a technological curiosity into a robust, validated, and indispensable pillar of modern oncology. This transformation began in earnest with her leadership at the Arizona Telemedicine Program, an initiative that became a living laboratory for the future of remote medicine. Arizona, with its sprawling deserts and dispersed rural and tribal communities, presented the ideal, a formidable, crucible for this experiment. The state's geography was a physical manifestation of the healthcare access problem she had so clearly defined. Her approach was systematic and holistic. It involved the comprehensive re-engineering of the oncological consultation for a digital medium. The fundamental challenge was to replicate the high-fidelity, high-trust environment of a specialist's office over miles of fiber optic cable. This required the creation of meticulous clinical protocols. A remote examination had to be more than a conversation. It demanded a structured process where a local primary care provider, guided by Lopez or her colleagues, could act as the oncologist's hands, using digital stethoscopes or high-resolution tampers to provide essential physical data. Every step was choreographed to ensure that the information flowing back to the academic medical center was as rich and reliable as an in-person assessment. Parallel to developing clinical procedures was the immense technical challenge of data transmission. In the late 1990s and early 2000s, this was a pioneering endeavor. The successful diagnosis and management of cancer depend on the expert interpretation of visual information of immense complexity. A pathologist's diagnosis hinges on the subtle morphology of cells on a glass slide. A radiologist on the faint shadows within a CT scan. Lopez and her team worked to establish systems capable of digitizing and transmitting these massive files with perfect fidelity, ensuring that a pathologist in Tucson could review a slide from a clinic hundreds of miles away with absolute confidence. This work in telepathology and teleradiology formed the bedrock of the program. It is a direct application of emerging digital imaging technologies to solve a pressing clinical need, a synthesis of engineering and medicine that was years ahead of its widespread adoption. She was influenced by the foundational work of figures like Dr. Michael J. Ackman, whose efforts at the National Library of Medicine with the Visible Human Project demonstrated the potential for digitizing complex anatomical data. Lopez translated that potential into a dynamic clinical service. Furthermore, she understood that cancer care is a profoundly collaborative discipline. The Modern Tumor Board, a conference where surgeons, medical oncologists, radiation oncologists, pathologists, and radiologists convene to devise a consensus treatment plan for a patient, is the intellectual heart of contemporary oncology. Recreating this essential forum was a cornerstone of her tele-oncology model. She implemented virtual tumor boards using multi-point video conferencing to connect specialists at the university with generalist physicians in remote communities. This allowed the collective expertise of an entire academic department to be brought to bear on a single case, regardless of the patient's location. A family physician in a small town could present a complex case and, in real time, receive guidance from a dozen world-class experts. This virtualized collaboration had the effect of upskilling the local providers, creating a sustained educational benefit that rippled throughout the state's healthcare ecosystem. The implementation of such a system, while a monumental achievement, was for Lopez the beginning of the inquiry. As a scholar, she recognized that innovation required validation. The Arizona Telemedicine Program became the subject of rigorous academic study, with Lopez as a principal investigator on numerous papers that quantified its impact. Her research, published in journals like Telemedicine and eHealth moves the conversation from anecdote to evidence. These studies meticulously documented the benefits they showed, with statistical significance, dramatic reductions in patient travel time and associated costs, removing a significant financial and logistical burden from families already stressed by a cancer diagnosis. One can almost detect a certain intellectual satisfaction in the data, the quiet elegance of numbers proving a humane hypothesis. Patient satisfaction surveys consistently showed high levels of comfort and confidence in the remote consultations. Crucially, her research demonstrated clinical non-inferiority. Patients managed through the tele-oncology program had outcomes that were equivalent to those of patients seen in traditional face-to-face settings. This was the ultimate proof of concept technology could successfully bridge the geographic divide without compromising the quality of care. This body of evidence provided a powerful argument for payers and hospital administrators, demonstrating that investing in telemedicine was a sound financial and clinical decision. It was the mathematics that allowed health systems to bet on virtual care, and, as her data showed, for everyone to win. This work created an intellectual and practical lineage. Her validated model for tele-oncology, particularly its hub-and-spoke structure connecting an academic center with peripheral clinics, became a blueprint for programs across the United States and internationally. Clinicians and health systems leaders seeking to establish their own remote specialty services would look to the Arizona experience as the gold standard. The protocols for remote examination, the standards for data security, and the framework for virtual tumor boards were all adopted and adapted by others. When the COVID-19 pandemic precipitated a global, instantaneous shift to remote care, the healthcare systems that fared best were often those that could rapidly scale up programs built upon the foundational principles that Lopez had spent 2 decades developing and perfecting. Her work provided the playbook when the world desperately needed one. Her influence is visible in the subsequent research of figures like Dr. Charles R. Thorne, a leader in global health and telemedicine, whose work on international and aerospace telemedicine builds upon the domestic, state-based models that Lopez proved were viable. Through this sustained effort, Lopez effectively solved the problem she had set out to address. She had conquered the tyranny of distance, using technology to project the expertise of a major medical center into the most underserved corners of the state. She demonstrated that the promise of academic medicine could, with ingenuity and rigor, be fulfilled for all. Yet, as the virtual bridges became stronger and the miles vanished, a more complex and subtle set of barriers came into sharper focus. With the geographical obstacles largely surmounted, it became increasingly clear that other, deeper chasms remained. The fabric of health disparities, she would find, was woven from threads of culture, language, and economic status issues that technology alone was powerless to resolve. The successful dissolution of distance revealed a new layer of complexity in the landscape of healthcare access. With data flowing freely across Arizona's vast expanses, the persistent inequalities in cancer outcomes between different populations became starker, the causes more sharply defined. The intellectual puzzle confronting Dr. Lopez had evolved. The question was a profound one. If a patient in a remote community and a patient in Phoenix could consult with the same oncologist, why did their prognosis so often diverge? The answer, her work would demonstrate, resided deep within the sociocultural and economic architecture of society itself. This next phase of her career represented a turn from the engineering of systems to the anthropology of care, from solving problems of physics to addressing the more intricate dynamics of human trust and belief. Her focus sharpened on the specific health disparities affecting Arizona's Hispanic and Native American populations. The data was unequivocal. These communities experienced higher incidence rates for certain cancers, were often diagnosed at later, less treatable stages, and faced poorer survival rates. The telemedicine network had removed the physical journey to the clinic, a monumental achievement. It had failed, however, to remove the cultural and psychological distance that separated many patients from the healthcare system. The problem was one of impedance, a resistance to the flow of care rooted in generations of experience, linguistic isolation, and economic precarity. To solve this, Lopez embraced a methodology that was, in its own way, as radical as the technological innovations. She had championed community-based participatory research, or CBPR. This approach was a profound departure from the traditional, hierarchical model of academic medicine. CBPR reframes the research process as a partnership. It posits that the community itself holds essential expertise about its own challenges and potential solutions. A physician-researcher becomes a collaborator, a facilitator who brings scientific rigor to bear on insights generated from within the community. In this, Lopez's work drew from the deep wells of public health theory on the social determinants of health, the understanding that factors like income, education, and social context are powerful predictors of well-being. Her methodology was likewise informed by the foundational work of medical anthropologists, scholars who had long argued that understanding a patient's explanatory model of illness, their personal and cultural beliefs about what causes sickness and what constitutes healing, is a prerequisite for effective care. The most tangible and powerful expression of this philosophy was her work with community health workers, or promotoras de salud. These individuals, predominantly women, were the linchpin of her strategy. They were recruited from within the very communities they were meant to serve, sharing the same language, cultural touchstones, and lived experiences. The promotoras fulfilled a role far exceeding simple translation. They were cultural interpreters, patient advocates, and, most critically, conduits of trust. They could enter a home and speak with an elder about the importance of a colonoscopy, framing the conversation within a shared cultural vernacular that an outside physician, however well-intentioned, could never replicate. They could patiently dismantle fatalistic beliefs about cancer, which some research published in journals like Cancer had identified as a significant barrier to seeking early screening. A statement like "it is in God's hands" could be gently reframed as a call to action, an affirmation that divine will is best served by using the tools of prevention and healing that are available. Through her research programs, Lopez and her team systematically documented these barriers and designed targeted interventions. They developed educational materials, fontanellers, radio programs, and pamphlets that were linguistically precise and culturally resonant. One study might investigate the specific anxieties surrounding mammography in a community, discovering that modesty and fear of pain were greater deterrents than a lack of information. The resulting intervention would then feature testimonials from local women, facilitated by a promoter, creating a powerful narrative of peer-to-peer reassurance. This was a form of social inoculation against the anxieties that kept people away from the clinic. The efficacy of these programs was measured with the same rigor as a clinical drug trial, tracking metrics like screening uptake, appointment adherence, and patient knowledge before and after the intervention. The results consistently demonstrated that this community-embedded approach yielded statistically significant improvements in health behaviors. It was a finding that offered a certain intellectual elegance. The most effective information protocol, it appeared, was a conversation in a language one understood with a person one trusted. The work produced a granular, high-resolution map of health disparities. It showed that for one community, the primary barrier might be transportation to a local clinic for a follow-up blood test, a problem solved with a simple voucher system. For another, it might be a deep-seated mistrust of medical institutions stemming from historical injustices, a problem that could only be addressed through the slow, patient work of building relationships, one promoter at a time. The influence of this work propagated through the academic and clinical worlds. Public health researchers and clinicians in other states began to adopt and adapt the CBPR and promoter models that Lopez had so effectively validated in Arizona. Her publications served as a blueprint for others seeking to address health disparities in their own regions, whether for diabetes management in urban Black communities or for improving vaccination rates among recent immigrant populations. Her work provided a powerful, evidence-based argument that investing in social infrastructure and cultural competency was a direct and effective form of medical intervention. She influenced a generation of health equity scholars by demonstrating that the tools of ethnography and community organizing were as essential to oncology as the scalpel and the chemotherapy agent. The solution to these persistent disparities was a human-centered one, requiring a deep and respectful engagement with the communities medicine sought to serve. This understanding would prepare her for an even broader challenge, reshaping the very experience of cancer care for all patients, regardless of their background. This commitment to the patient's lived experience found its most powerful expression in her pioneering work within integrative oncology. Here, the intellectual challenge expanded from ensuring access to care toward fundamentally redefining the quality of that care. The central problem was an old and agonizing one, a paradox at the heart of modern oncology. The very treatments designed to save a life often waged a devastating war on the body and spirit. For decades, the debilitating consequences of chemotherapy and radiation, the relentless nausea, the profound fatigue, the searing neuropathic pain, the pervasive anxiety, were frequently framed as the unavoidable price of survival. A patient's quality of life was an important consideration, yet the tools to actively manage it were limited, leading many to simply endure. Lopez saw this as a profound clinical and ethical failing. The mission became to assemble and validate a therapeutic arsenal aimed squarely at the patient's suffering, transforming the experience of cancer treatment from one of passive endurance to one of active, holistic support. Her approach was characterized by a methodical and discerning application of scientific principles to a field often clouded by unsubstantiated claims. The world of complementary and alternative medicine was a vast, unregulated landscape containing everything from ancient healing traditions to modern charlatanism. Her singular contribution was the introduction of a rigorous evidentiary filter. She championed a framework where therapies like acupuncture, meditation, and yoga would be subjected to the same level of scrutiny as a new pharmaceutical agent through randomized controlled trials, systematic reviews, and meta-analyses. This intellectual discipline was essential. It allowed for the crucial separation of evidence-based practices, which could be safely and effectively integrated into conventional care, from the vast sea of pseudoscience. In this endeavor, she built upon the foundational work of early investigators who had begun to lay the groundwork for this empirical validation. Researchers like Barry Kassilov at Memorial Sloan Kettering Cancer Center had already initiated some of the first rigorous studies on the role of complementary therapies in the 1980s and 80s. Their preliminary findings, often published in specialized journals, provided the initial sparks of evidence. Lopez's role was that of a synthesizer and an amplifier. She took these early, sometimes disparate, threads of research and wove them into a coherent, powerful argument for a new clinical paradigm, advocating for their inclusion in mainstream oncological practice and policy. The practical applications of this philosophy were specific and transformative. Consider the problem of chemotherapy-induced nausea and vomiting, a side effect so severe it could lead patients to abandon life-saving treatment. Drawing upon a growing body of clinical trials, Dr. Lopez became a leading voice for the integration of acupuncture. She articulated the evidence showing that specific acupressure points, like the pericardium 6 point on the inner wrist, could significantly reduce nausea, functioning as a powerful adjunct to standard antiemetic drugs. Her advocacy helped move acupuncture from the periphery of medicine into the heart of cancer symptom management, providing clinicians with a validated, non-pharmacological tool to improve patient tolerance of treatment. A similar logic was applied to the pervasive and disabling condition of cancer-related fatigue. This was a profound, bone-deep exhaustion untouched by rest, affecting the majority of patients and persisting for months or even years after treatment. Standard interventions review. Dr. Lopez championed the evidence emerging from studies on mind-body practices. She highlighted research demonstrating that structured yoga programs tailored for cancer patients could lead to statistically significant improvements in energy levels, physical functioning, and overall vitality. The mechanism was multifaceted, likely involving reduced inflammation, improved sleep quality, and a restored sense of bodily agency. By promoting these findings, she gave physicians a concrete prescription to offer their exhausted patients a proactive strategy to reclaim a degree of their former strength. The same rigorous, evidence-based approach was directed at the psychological toll of the disease, validating mindfulness meditation as a clinical tool for reducing the anxiety and depression that so often accompany a cancer diagnosis. This sustained effort to build an evidence base culminated in her leadership of the field's most important professional body, the Society for Integrative Oncology, or CO. During her tenure as president, she spearheaded the Society's most impactful initiative of the development and publication of clinical practice guidelines for integrative therapies, created in direct partnership with the American Society of Clinical Oncology, or SCO. This was a landmark achievement. These guidelines provided, for the first time, a clear, authoritative, and evidence-graded roadmap for practicing oncologists. A clinician anywhere in the world, faced with a patient suffering from treatment-related side effects, could now consult a document that specified which integrative therapies held strong evidence of benefit for which symptoms. The SIO-SCO guidelines on integrative medicine for breast cancer, for example, gave an grade to meditation for reducing anxiety and depressive symptoms and to yoga for improving quality of life. They provided specific recommendations for managing pain and fatigue, all backed by transparent review of the available clinical trial data. The direct influence of this work was immense and immediate. It armed oncologists with the confidence to recommend these therapies, transforming conversations in clinics and tumor boards. It gave legitimacy to hospital-based integrative medicine programs, spurring their growth and ensuring they adhered to high standards of evidence. Dr. Lopez's leadership in this process directly influenced a generation of oncology practitioners, providing them a validated toolkit that expanded their ability to care for the whole person. The physician was empowered to offer something more than sympathy for a patient's suffering. They could now offer a set of evidence-based interventions to alleviate it. Through this work, Dr. Lopez constructed another essential pillar in her vision for a more humane system of medicine. Having already addressed the structural barriers of access through telemedicine and the societal barriers of inequity through community engagement, she now tackled the experiential barriers within the clinic itself. She demonstrated that a patient's well-being was a clinical outcome that could be systematically measured and improved. This pillar of integrative care, with its focus on the patient's complete physical and emotional state, would prove to be a crucial component of the comprehensive, patient-centered future she was beginning to architect on a national scale. The establishment of integrative oncology as a clinical discipline provided Dr. Maria Lopez with the final foundational element for a much broader architectural project. The intellectual and practical frameworks she had constructed over decades, telemedicine for access, community-based programs for equity, and integrative methods for holistic well-being, were now ready for synthesis on a national stage. Her ascent to the presidency of the American College of Physicians, the largest medical specialty organization in the United States, offered the ideal fulcrum to leverage this accumulated wisdom. Here, the problem she confronted was the inertia of the entire American healthcare system. The challenge was to translate her proven, yet localized, principles into national policy, embedding them within the very DNA of medical education, professional standards, and healthcare financing. Her solution was a sophisticated campaign of advocacy and visionary leadership aimed at reshaping the profession from within. Her presidential platform for the ACP became the definitive expression of this synthesized vision. It was an elegant and compelling argument for a more rational and humane system of care, with each tenet flowing logically from her life's work. One central pillar of her agenda was the urgent issue of physician well-being. Drawing a direct line from her deep engagement with the patient experience, she posited that the capacity for compassionate, holistic care was intrinsically linked to the health of the clinician. A system that produced widespread burnout, she argued, was a system that fundamentally compromised patient safety and the quality of care. Her advocacy led the ACP to champion initiatives aimed at reducing administrative burdens and addressing the systemic drivers of professional distress. This was a principle of integrative care scaled to the level of the entire profession, caring for the caregiver as a prerequisite for caring for the patient. This perspective was deeply informed by the work of figures like Dr. Shanae Folt at Stanford, whose research provided the empirical backbone for understanding the epidemiology and consequences of physician burnout. Lopez's unique contribution was to weave this evidence into the fabric of national physician advocacy, framing it as an issue of public health. A second, equally vital component of her leadership was the formalization of health equity as a core professional competency. Her decades of experience in Arizona, creating programs for rural, indigenous, and Hispanic communities, had given her an unparalleled ground-level view of systemic disparities. As ACP president, she worked to move this issue from the periphery of medical discourse to its center. She championed policies that called for medical schools and residency programs to integrate training on social determinants of health, cultural competence, and the mitigation of implicit bias directly into their curricular. The goal was to produce a generation of physicians who understood that a patient's zip code could be as predictive of their health outcomes as their genetic code. This was the logical culmination of her early telemedicine work, which began as a practical tool for overcoming geography and evolved into a profound recognition of the myriad structural barriers to health. Her leadership influenced the accreditation standards for medical education and shaped the policy resolutions adopted by the ACP, which in turn guide the lobbying efforts and public statements of the organization affecting health legislation at the federal level. A third element of her national platform involved the powerful advocacy for value-based care models. This represented a direct challenge to the prevailing fee-for-service system, which incentivizes the volume of procedures over the quality of outcomes. Lopez's work in both telemedicine and integrative oncology had already demonstrated the immense value of proactive, patient-centered management that improved well-being and often reduced the need for more intensive, costly interventions. She became a prominent voice arguing that payment systems should reward physicians for keeping patients healthy, for managing chronic diseases effectively, and for delivering care that aligns with patient goals. This was a vision of medical economics that saw value in a long, thoughtful consultation about lifestyle changes or in a coordinated telehealth visit that prevented a hospital admission. Her advocacy built upon the conceptual work of health economists like Michael Poore and policy leaders like Donald Barrick of the Institute for Healthcare Improvement. Lopez's role was to translate these powerful economic and ethical arguments into a practical agenda for internal medicine, articulating how primary care physicians and specialists could thrive and lead such a system. The enduring impact of this period of national leadership is seen in the cohort of physicians and health system administrators who worked with her and were shaped by her vision. Through her mentorship, her policy initiatives, and a powerful example of her own career, she influenced a generation of leaders who now carry her synthesized approach forward. These are the medical school deans who are redesigning curricula to include health equity, the hospital executives who are investing in robust telemedicine infrastructure, and the young physicians who enter practice with an innate understanding that their role extends to advocacy and systemic reform. They see these different domains as interconnected facets of a single professional identity. Dr. Lopez's ultimate contribution, therefore, resides in the powerful coherence she forged from seemingly disparate fields. She articulated and then embodied a new archetype for the modern physician, a figure who is simultaneously a rigorous clinical specialist, a savvy technology innovator, a tireless social justice advocate, and a profound champion for the complete well-being of both patient and practitioner. This integrated model, demonstrated through a career of relentless and compassionate innovation, is her most significant bequest to American medicine. It provides a comprehensive, actionable blueprint for a more equitable, accessible, and humane future, a legacy that continues to shape the very definition of what it means to heal.
We really appreciate you tuning into this AI-powered presentation. Our goal is to push the boundaries of AI in content creation, and your input is invaluable. If there's a particular subject you'd like to see us tackle next, or if you have suggestions on how we could fine-tune our AI's creative prompts, please don't hesitate to leave your ideas in the comments section. We're excited to bring you more unique content very soon.